I was giving this the talk about the optional treatment for aortic valve disease in young adults in 2024. So these are my disclosure. So, the valvular heart disease is a kind of that the trend and disparity in across the world has been then quite kind of known. And aortic valve disease is a kind of probably most commonest the disease condition. And this is a kind of the trend looking at the United States, 1999 to 2020. And then followed by kind of the mitral valve and then mixed valve disease. Then when you look at the sex difference in the survival from these kind of the aortic valve stenosis and aortic regurgitation, and then you can see that the more kind of male kind of had the kind of mortality, even with both aortic stenosis as well as aortic regurgitation. And then if you look at the global trend of the burden of the valvular heart disease from the clinical epidemiology in terms of management, you can see that from the one side, degenerative mitral valve disease, the other side, calcific aortic valve disease, and the prevalence, you can see that from the pyramid of the kind of the amount of kind of the population affected and in the kind of in the over period of time. So we know that this is kind of ongoing, and then probably going to be ongoing issue for. We know that the older generation population is expanding, and but at the same time, more and more kind of the younger generation of patients and also been diagnosed to have the aortic valve disease. So when you look at the outcome for these patient factors, I'll go to that. Yeah, next one. Um, yeah. Yes, so look at that's where the kind of in the epidemiology, look at the outcome in the US. And then there was from the group, it is all valve types, mechanical biprosthetic, allograft, homograph, and Ozaki, and TAVA. This is a kind of US population from the SCS data. And going back, there's one other slide upside down. I'll explain to you as we go along. And this is for the patients younger than 55 years old. So you can still see the kind of over kind of 447 patients had a TAVR procedure for aortic valve disease in this kind of cohort of young patients. And the majority are mechanical valve, and then reasonable number of bioprosthetic valve. And the postoperative outcome, you can see the mechanical valve at the outcome mortality 3.3%, bioprosthetic 3.7%, and the homograph. Obviously, autograft is a Ross procedure. Patient group always tend to get a lower mortality because they operated by kind of senior expert surgeon and small number of procedure. And then homographs as well kind of have a high incident mortality, partly because they probably use it for endocarditis procedure and the Ozaki procedure and TAVR procedure. And also when you look at the stroke, post-operative stroke, you can see the difference in the TAVR procedure get about 2.7%, but mechanical is 1.5% and bioprosthetic 1.5%. So at that stage, and in 2023, and when they look at it, there's 6 valve options at this moment in time with but among all, low early mortality and low stroke rate favor the surgical aortic valve replacement in this patient group. And then the practice will likely to evolve over a period of time, and because of TAVR improvement in technology, and also the surveillance data will become more available to push the boundary further. And then when we look at the outcome of surgical aortic valve alone, and this is a paper from the Canada group and in the Eastern Europe, and saying looking at the 30 years of the outcome of the aortic valve replacement, and then 20 years survival with the relative kind of survival was 60.4%, but actual survival was 24.2%. But still, it is kind of good the outcome for 10-year survival. And then so they think that the younger patient group will be in favor of surgical aortic valve replacement. And then when you look at the comparing bioprosthetic valve and mechanical valve, and then Australian series from 2003 to 2018. The aortic valve, 3,969 aortic valve between patients between kind of 55 to 64 years when you compare that. And you can see that up to 10 years, there was no major difference between the two groups. And beyond the 10 years, bioprosthetic valve group starting to increase the mortality. And because of this is an all-cause mortality. So they feel as though this patient, younger patient group, and then even though you can use a tissue valve, mechanical valves is kind of beyond 10 years seem to have kind of better kind of quality outcome. But and then there's also support for the use of tissue valve in this patient age group for treating for 10 years or 12 years with subsequent interim and the subsequent treatment modality to improve that quality. So we will come back to that eventually because the whole thing is about lifetime management rather than one valve is better than others. And then comparison between the two patient groups or the patient younger than kind of 65, and you can see that 18 to 54 years old, so between up to about 12 years, there's no difference. And then when you look at the 55 to 64 years, and also kind of 10 years, up to kind of beyond 10 years is no change at all. Then gradually lines starting to split in favor of mechanical kind of the prosthesis in the kind of long-term kind of mortality. And then if you look at cumulated reoperation rate, obviously for younger patient group, from 7 year up onwards, they're starting to rise in reoperation rate. Beyond 10 to 12 years, reoperation rate is higher compared to kind of mechanical valve. But 55 to 64 years, that's where the importance is. We can see that there's not a lot split between the two lines. So the either biological valve or the tissue mechanical valve in 55 to 64 years old is relatively comparable for this patient group. So that's kind of advantage to think about how you're going to choose the patients and therefore for the treatment. And then also when you look at the post-op mortality for looking at the vas sparing route, because for those patients who had the aortic root disease, want to do the valve is repairable and spare the valve. Some people may say this is not the aortic valve disease, it's aortic disease. And some patients come with bicuspid valve, may be repairable. Some are tricuspid valve with prolapse and repairable. And then they can have a kind of very kind of early outcome as well as reasonable follow-up and there's survival as well as freedom from intervention to. But the question is depends on the individual group. If you are having a high volume center and doing kind of people doing enough operation, the vas sparing route, your outcome will be better compared to if you're doing small number. Then the long-term durability, if you look at it, you can see that the moderate to severe AR group is probably, and then they need to kind of about the around that beyond the 7 year onwards, starting to affect, and then but survival for is quite good. And then what about comparing autograft versus homograph? Because homograph and autograft, and when you look at it, the Ismail El-Hamisi together with Magdi Yaqub, and then they look at the 228 patients randomly assigned to the autograft versus homograph, and then they have the follow-up period. So you can see the kind of aortic regurgitation, the grade 1 is majority patient grade 1, and then up to about 10, 11 years, beyond that starting to have more of a grade 2 aortic regurgitation patient. And so it is, and then when you look at in the homograph group, and that is much higher compared to autograft group. And then when you look at the long-term outcome for autograft versus homograph, and so 8 to 10 years and the kind of comparison between the autograft and homograph, you can see the survival advantage of the autograft over the homograph beyond the 10 years clearly, because you can see the big drop out in the kind of survival. And the same is true for freedom from any reoperation. And then long-term outcome, and then when you look at the kind of survival data, you can clearly see that there's a difference there. So how about Ozaki procedure? Because we need to talk a little bit about Ozaki procedure. I'm not sure how many people do Ozaki procedure regularly, but I don't practice it, so I can't say a lot about it. But with this comparison between the Ozaki procedure, they look at 776 Ozaki procedure from 2007 to 2016, and the isolated procedure, and they have a two kind of times of one, a learning curve kind of periods followed by, and then more of a kind of established part of the kind of the practice, and then they will then compare with the Paramount area at time. So comparison. So they come with the propensity score match to 627 on each group to see the kind of any difference between Ozaki procedure and then Paramount Magna kind of aortic valve. So when we look at the AR grade, and then with the kind of between the two groups, you see that it is up to 6 years, and then there's for no major difference. And then obviously kind of severe aortic regurgitation group in the Paramount Magna is less compared to Ozaki procedure. And then when you look at these Paramount, obviously that the peak gradient is higher compared to Ozaki procedure peak gradient. So this is the kind of procedure can give you very low the peak gradient. And then redo replacement requirement. So compare with Ozaki and then Paramount Magna East for out to 6 years, and there's no major difference between. So intermediate outcome for Ozaki procedure in the kind of the appropriate hand compared to Paramount Magna, the outcome is similar in the up to 5-6 year duration. And then what about, so we see the young adults with the smaller annulus. So I just wanted to highlight this one about the Boyang kind of the aortic root enlargement and annular enlargement is you can see the kind of that's increase in the at least a 2, possibly 3 sized increase in annular these valve sizes for these aortic valve replacement and maintain a very low gradient and then decent outcome, and definitely it is early outcomes been good. And then so we got mix of everything there, and then in the meantime, because we compare the autograph and the homograph, and with the resurgence of the Ross procedure, especially with the kind of and the Ismail El-Hamisi has kind of pushed his kind of data forward, and then comparing with Ross procedure versus a prosthetic aortic valve replacement adult. And we can see that with the Ross procedure, and the mortality risk is during the follow-ups is low, and then also reduce endocarditis risk compared to biological aortic valve or the mechanical valve, and the stroke risk is lower. And so median follow-up at 12.5 years. So if you look at that with that, so you can see that there's an advantage of Ross procedure over the conventional kind of the aortic valve replacement. But we need to discuss about how some people get a very good result with the Ross procedure, why other people don't, and especially beyond 10 years. So I think it is quite important for us to take that into account when we make the decision. And then so at the moment, so when I showed earlier about a few slides comparison, so we had 6 possible things that I said that was the first slide that was switch around. So you can see that over 2023 to 2013 to 2018, in the 45,000 patients that what they look at in the STS database, you can see that that small number of patients having more kind of aortogram, Ozaki, and then Tava. And then most resurgent one is still a homograph still. But you've seen the kind of outcome from the earlier on with these kind of slides before. You can see that at present time, between all the 6 options available, probably surgical valve replacement still has a low, more reproducible and lower mortality and especially lower stroke rate. So still kind of the choice of the kind of valve for procedure for young adults and then at the moment. And this is a kind of editorial from the Richard Whitlock and the kind of colleague. It's very, very kind of logistic to think about. The surgeon expertise is important, what we want to do, and the training and the developing your program, and also patient's value and culture and patient preferences. We need to take into account whether patient want to have the pregnancy, child cannot reproductive life to be over before they will take the kind of warfarin, or whether they may have some other religious belief that want to choose one over other. And then sometimes because of their preference in the engaging in the kind of high risk sports and everything else, or the occupational has that, like people who are kind of fighter plane fighter jet fighters and the kind of pilots, and then they need the aortic valve replacement. They want to have something without needing the kind of warfarin, obviously. And so all the characteristic, patient value and preferences and surgeon expertise come together, then you can then decide a surgical risk versus anticoagulation risk versus the valve durability and the long-term outcome. What's the size of the annulus at the first time, whether we need to do a kind of re-enlargement to start from the first thing, or we just do the kind of the valve or the valve repair and the valve kind of the stabilizer kind of procedure until they get over another 10 years. So it is not straightforward, even though we like to think straightforward. And also socio-economical status. I came from Myanmar, Burma, so my patients can't have a 2-3 operation in a lifetime. They have to pay for it, and they can't afford to pay 3 operations. And some people might just want to afford for 1 operation in a lifetime. Or some patients for younger, the female, for mitral, rheumatic mitral, they need a 2-3 mitral valvotomy before they can get to the kind of redo valve replacement. So you need to make the plan for that kind of lifetime management. So in conclusion, at present surgical AVR is a choice for this younger age group. And the transcatheter valve implementation will play increasingly more as technology improve, and the long-term surveillance data is important for the future direction and how we will make the decision and how we can discuss with the patients. It's important patient-specific, individual, lifetime management is a key. So we need to get the patient involved and all the way through the journey of the lifetime with their aortic valve journey. Thank you.